Good morning, everyone. Thank you for joining us today for our fourth Community of Practice Lunch and Learn webinar. My name is Newman, and I'm a project coordinator at the Center for Behavioral Health and Justice, a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. This webinar is part of our Opioid Treatment Ecosystem Initiative, OTE, which is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into the larger community of practice, including all of you who have joined us here today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensure continuity of care to prevent overdose upon release from jail, and connect first responder and behavioral health systems to increase community-based treatment access. Today's event, and all those we hold in the future, will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. Generous support from the Michigan Health Endowment Fund has made it possible for us to offer this event as part of the OTE community of practice. Before we get started, we do have just a couple housekeeping items. Audiovisual capabilities have been turned off for attendees to limit distractions throughout the presentation, but we encourage you to ask questions of the presenter. You may enter your question into the Q&A box on your screen at any time. We will address questions as time permits during the discussion portion of the event. If you are calling from a phone, you would press *9 to raise your hand and ask your question. Next slide, please. To kick off the event today, I'd like to introduce Doe-Simkins. Doe-Simkins has been in the public health field for 20 years, training on and researching such varied topics as HIV prevention, harm reduction and safer drug use, and overdose prevention. Maya is particularly interested in the integration of public health, substance use disorder, and mental health treatment with a focus on evidence-based practices like opioid agonist treatment, syringe access initiatives, and overdose prevention practices. She has worked with the largest overdose prevention program in the United States, helped launch the first overdose education and naloxone distribution program using nasal naloxone, and was part of the team that published the first effectiveness studies on community naloxone distribution. She has worked with both grassroots and local and state governmental organizations to establish overdose prevention programs, authored manuals and curricula, and published scientific research. Thank you so much for joining us today, Maya.
Hi, good morning. Thanks so much for having me. I'm really excited to have this conversation with y'all during this Lunch and Learn. I'm looking forward to chatting about harm reduction and correctional settings with some opportunities to improve the health and well-being of people who use drugs. Can we go to the next slide? We'll just jump right in. I'm going to do just a little bit of background about what is harm reduction. So in the context of drug use, and harm reduction is a philosophy that can be applied beyond drug use, but we're just talking about, for today's purposes, in the context of drug use, harm reduction is pragmatic and compassionate. It's an approach to reduce the harmful effects and maximize the positive effects of substance use through practical, reality-based steps that focus on the harms that the person themselves sees as problematic. That's one component. Another foundational component of harm reduction that sometimes I see missing or more challenging to incorporate is the concept of nothing about us without us. This is something that came out of HIV activism and the ACT UP crew, and we really need to, when we're thinking about harm reduction-based programming, we really need to authentically ask the questions: who is in the room making decisions, and who has actual, true, authentic power in decision-making and programmatic decision-making and implementation decision-making. And to that, to sort of underscore that point, I want to point out this quote from the National Urban Survivors Union, which is a drug users union, that says, "We don't just need to be, quote, at the table. We created the table, we are the table." And this is important enough that, this is important because programming that has sort of inauthentic involvement of participants or consumers is pretty obvious to the participants and consumers. And then the third really important component about harm reduction is that it acknowledges and actively works to correct inequities, and in particular in the context of drug use, racism, and the way that racism has influenced the war on drugs. So next slide, please. A few characteristics of harm reduction-based services are, one, that individuals have a voice. And by that, I mean an authentic voice. I've seen wildly different applications of things like a consumer advisory board, and some are kind of performative, and some are truly meaningful and, have, for example, some places had the consumer advisory board has access to the board of directors. Some cases it's part of the board of directors. That's a true example of a true authentic voice for folks, compared to something like consumer feedback surveys that might be sort of posted on a wall once a year or something like that. Not to say that that isn't meaningful, it's just not it doesn't come with accountability for the voice of the individuals. Another characteristic is that there's a focus on reducing harm, which is not necessarily the same as reducing consumption. In many cases it is, but in many cases it also is not the same. There are no predefined outcomes, and I just really want to acknowledge that this is particularly challenging if we're going to be practical, given that many programs and many services are funded with the intention of an outcome. They're funded for HIV prevention, or they're funded for treatment retention, or recidivism reduction, et cetera. And so it's challenging to have harm reduction-based services where there are no predefined outcomes for an individual, and yet the outcomes we may be mandated to have outcomes by funders, for example. And then another component is that individuals' decision to engage in risky behaviors is accepted, which also means that the individual is expected to take responsibility for their own behavior. So there's no, there's not specific judgment around engaging in risky behavior, and there's not exemption from responsibility of that risky behavior. And then also an individual is treated with dignity. So how about the next slide, please? I also want to point out that harm reduction is a philosophy. It's a way of seeing, treating, and interacting with people, and it's not a set of services. The set of services that improves the public health of people who use drugs is public health. Those are public health services. If you're doing harm reduction, I really love this quote by my colleague Daniel Raymond that says, if you're handing out syringes and naloxone, you're absolutely doing a good thing. That's good public health. But if you're not doing harm reduction unless you're actively building power with directly impacted people. And that's the component of harm reduction that is meaningful and also sort of evidence-based to enhance people's quality of life outcomes. Next slide, please. Another definition of harm reduction that has largely been popularized by the Chicago Recovery Alliance is that harm reduction is any positive change, and then there's a caveat to that, any positive change as the person defines it for themselves. So some example of harm reduction successes for people using drugs could be, for example, to quit using drugs altogether. And I have many, many colleagues who have needed to quit using drugs altogether. And then the next one, please. So using less or less often is another option for a success in a harm reduction program. Using safer injection practices, so not necessarily changing the volume or the amount or the frequency with which you use, but using in a way that's going to help avoid viral infection or skin and soft tissue infections with safer injection practices. Next one. Accessing tools for safer use, and this is clearly, this is most obvious and easy to conceptualize in the context of people who inject drugs, but also, folks who smoke or snort their drugs. There's ways to consume drugs in those manners that are more risky and less risky. So accessing those tools for safer drug use is another success in a harm reduction program. Next one. So another, and this goes back to the meaningful role of people who use drugs, learning to teach safer practices to others, learning to engage in mutual aid with within a drug using community is definitely considered a success of a harm reduction program. Next one. We could consider is when we go back to the idea of what are the harms that the person would like to reduce for themselves. Reducing the time spent in jail or prison is absolutely a success. Go for it. And assisting in access to healthcare, both physical and mental health care is something that if folks can access and pay attention to some of those things, it might offer up the opportunity for substance use to be less primary and less important in their lives after some physical or mental health issues have been addressed. Next one, please. Accessing housing. Accessing housing is something that we know reduces recidivism in the correction setting. It also improves substance use disorder outcomes as well. Next one. Expanding or enhancing or extending social networks. So new friendships and support networks is absolutely considered a success. Go for it. Just getting used to and comfortable with the idea of talking about the pros and cons of drug use with providers or other important members of a support network. That is a very reasonable success. Next one. Feeling valued, having feelings of self-worth is one of the ways to bulk up recovery capital, where people begin or people feel like their worth in their contributions to their community and their society are important enough that they're worth preserving in a variety of different ways. So that's another success. Go for it. And then being taken seriously and not feeling infantilized. And this is something that happens from time to time in substance use disorder treatment. It can also happen in certain correction settings where people, adult humans capable of making decisions for themselves, feel as though pretty basic decisions are being made on their behalf. So let's move on. Particularly in the context of corrections and harm reduction, I think it's really important to acknowledge, given that the harm reduction is a philosophy that relies really deeply on autonomy and an active transfer of power to people who use drugs. We really have to acknowledge the contradictions in the context of corrections, where people's freedoms are restricted, decisions are made for people, and options that are available to them are less than if they weren't involved in corrections. Nonetheless, it's an opportunity to brainstorm areas of overlap with harm reduction and correction settings, given that the overlap of people who engage in both of those systems is enormous. So next one, please. And I just want to, going back to the public health component of the public health services that reduce harms for people who use drugs, I just want to point out that reducing risk is normal. We do this all the time. We do this with, sunscreen. We know that too much exposure to the sun these days is not good for our health. We know that until very recently, car crashes, motor vehicle crashes were the #1 cause of injury-related death before it was overtaken by drug overdose just in this past decade. So we use seatbelts to reduce risk. We have speed limits to reduce risk. We also, there's, in the context of unplanned pregnancies, there's always a risk, and birth control helps reduce that risk. And then even something that like filters on cigarettes, even filtered cigarettes are wildly risky, and yet they're less risky than unfiltered cigarettes. So reducing risk is something that is absolutely normal. And I really think that it's important to acknowledge the public health services like syringe access programs that aren't at their core, it's not it's not really that controversial to the concept of reducing risk when many of us engage in risky behaviors that we know to be risky or risky activities, and we do so anyway, and we work to minimize that risk. So, all right, next one. So I'm going to just talk about two major examples of opportunities for maximizing the health and well-being for people who use drugs in a correction setting. So the first example is going to be overdose education and naloxone distribution, and I shorten that to OEND. Next slide, please. A little bit of background here is I want you to take a peek at this graph on the what is that? The right. Yeah, the right. It starts off in 1999. The graph officially goes to 2017, but I was looking for this exact same graph that was updated, and whew, y'all, I spent like 15 or 20 minutes looking for this graph that was updated with 2019 numbers, and like the CDC just did not have the same graph. So anyway, I left this graph because I want to pay attention to the trend in national drug overdose deaths. But then that 50,042, I just put that number in there, which is our 2019 numbers, just so you can see that there is this increasing trend and that over time. And I wanted to lay that over these key events with overdose education with incarcerated people, so that we can just see what was going on with the overdose death rates at these points in history. So in 1996, which is before this graph even starts. So 1996, we've known that overdose is a major risk. In fact, it is the major risk of fatality for people upon release from incarceration. 1996 is also an important date because it is the year that the first community-based naloxone distribution program was developed in the United States. So that's a long time ago, 96. And then we fast forward many, many years to 2011, and we look at, we see that there's naloxone upon release in the UK and in Scotland and in the United States in Rhode Island. Rhode Island is a really special kind of place with their corrections options. They have one state prison, and so they were able to launch that pretty quickly. That was in 2011, and just notice the numbers here, on the graph of 2011. In 2012, the N-Alive trial began, and that was a huge randomized control study with people upon release from incarceration. It enrolled to begin with 5,000 people, and then was going to enroll 50,000 people, and it was in the UK. So that happened in 2012. By 2014, the N-Alive trial stopped randomizing. They ceased that. They stopped that program because they had discovered the incredibly powerful effect on fatal overdoses that having access to naloxone provided people upon release from incarceration. And it was considered unethical to keep randomizing people to a no naloxone arm once those results of incredible protectiveness of naloxone became known. And so let's just contextualize 2014 on this graph is still nowhere near. I mean, we're looking at less than half of the deaths that we see in 2019 from drug overdoses involving opioids, and it was in 2014 that we stopped randomizing that study because it was unethical. So my question is really, what is taking so long when we know that overdose deaths is the #1 cause of fatality upon release from incarceration? Let's go to the next slide, please. Not only is overdose death the #1 risk for people upon release from incarceration, but the N-Alive study also came up with an astounding finding. And I'm just going to quote this from the research article that Sheila Bird put out in 2014. It says that evidence demonstrate that notwithstanding the ex-prisoners' very high risk of overdose death soon after release, their altruism and concern for others is such that when naloxone is administered, the recipient is twice as likely to be someone other than the ex-prisoner. And so let me just paraphrase that. People get out of jail or prison, get naloxone upon release, and then at double the rate, they are saving people's lives in their community more than their own lives are being saved upon release from incarceration. So not only do we know that it saves individuals' lives, it saves community members' lives to give people naloxone upon release. And I just want to quickly reference this awesome video called Staying Alive on the Outside. You can look it up yourself on YouTube. It's a lovely, lovely video put out by some folks in Massachusetts or Rhode Island. Yeah, take a peek at it. I'm not going to show it. It's 17 minutes long, but I really am a big fan of it. So yeah, let's move on to the next one. In the context of providing naloxone upon release to people who use drugs, there's a lot of models. You can, there's a self-contained model where, the facility itself provides naloxone to people who, who are incarcerated. And this could be either, corrections officers, or it could be healthcare providers that are operating within those systems. It could also be an outside agency comes into the lockup facility and provides the education in the naloxone. Another option is training can happen on site, and then referrals for naloxone upon release can be made. This one is, people always think of it, and it makes sense just because it's logistically less burdensome, but we also know that the risk for death upon release is particularly high in the first few days after release. And so having the naloxone right there and not relying on a referral is probably a great idea. Another really clever idea that I've seen is providing naloxone education and the materials to families during visiting hours, oftentimes in waiting areas, for example. There's great peer-to-peer education for naloxone and overdose prevention trainings. And then a couple places have started using vending machines for naloxone access. With the biggest and most established project is in the LA County Jail, which is the largest jail in the country. And they have, if I remember correctly, the last time I talked to them, they had distributed 27,000 naloxone kits in less than a year using vending machines. So there's a lot of ways to do this, and there's a lot of models and opportunities, and there's long-standing evidence of the deep, powerful death prevention effects, not only for people who are incarcerated, but also for their community. Next slide, please. The next example I'm going to talk about for harm reduction and corrections opportunities to improve people's health is pharmacotherapy for substance use disorders. Next slide, please. We're just going to include this slide here on medications for opioid use disorder, specifically on treatment outcomes. So this is a comparison chart of buprenorphine, bup, which is the first column, the second column after the outcomes. And then methadone is the third column, and then XR naltrexone, which is also brand name Vivitrol. I want to point out that buprenorphine and methadone have some additional beneficial outcomes above and beyond what extended release naltrexone has. So all of these three options, these are the only FDA approved medications for opioid use disorder at the time. Both medications have increased, or all three medications have increased retention in treatment and reduced illicit opioid use. We also, when we're looking at buprenorphine and methadone, we also see reduced risk for fatal overdose, reduced all-cause mortality, and reduced HIV transmission risk behaviors. Next slide, please. So for that reason specifically, and given that there's a little bit of an imbalance in terms of medication access in the context of incarcerated people, there's more access to extended release naltrexone than there is for agonist-based treatments like methadone and buprenorphine, despite the fact that methadone and buprenorphine actually have additional benefits beyond what extended release naltrexone can offer. So for that reason, I'm going to focus specifically on opioid agonist treatments, OAT. So that would be methadone and buprenorphine. And the reason I want to focus that is that they have the biggest overdose prevention effect of any intervention that we know of. And so that's particularly meaningful for me because most of my professional life has been focused on naloxone access to prevent fatal overdoses. So I've been doing this for many, many years. It's been one of my passions, but I want to really clearly acknowledge that access to agonist treatment has an even bigger effect on preventing fatal overdoses at a community level than even naloxone access. It is the most effective overdose prevention intervention that we know of right now. We also know that methadone and buprenorphine have a positive effect on recidivism, which is meaningful in the context of corrections as well. And specifically, I've heard this many, many times over the years that people talk about opiate withdrawal being wildly uncomfortable, but it's not going to kill you. And I just want to correct that assumption or that statement and say that withdrawal absolutely can kill you. And the most common context in which withdrawal kills people is in jail. And that is because with severe withdrawal symptoms, people's get dehydrated and suffer either from dehydration or what do you call it? Like their metabolites get out of whack. That's my technical term. Their metabolites get out of whack. But we see every single year, we see multiple fatalities in jails from withdrawals. So by and large, in broad sweeping statements, it's true that opioid withdrawal is painful and often not fatal, but the most common context is in incarceration, in jail settings, over prison, for example, but definitely jail. Next slide, please. I want to focus just a little bit on some really exciting research on methadone maintenance during incarceration. So these are folks who get inducted into methadone while they're incarcerated. And these are outcomes 12 months after they've been released from incarceration. We see that there is lower injection drug and lower heroin use amongst this group of people. We see fewer non-fatal overdoses. And it's important to, of course, differentiate between fatal and non-fatal overdoses, but one of the biggest indicators or risk factors for a fatal overdose is a previous non-fatal overdose. So fewer non-fatal overdoses among people who got their methadone maintenance inducted in while they were incarcerated. And then there's higher rates of engagement in treatment. And I just want to, circle back to Rhode Island. I know that there's a lot of logistical logistical hurdles, with implementing methadone access in incarcerations, in correction settings, but it's been going on in Rhode Island since 2001. That's nearly 20 years. So there's absolutely models out there that we can look to for implementing. Next slide, please. I also want to just, say that engagement in methadone has lots of powerful benefits, even if the people continue to inject drugs. And that might seem counterintuitive, but this is a study that was done among people who are engaged in methadone maintenance and also go to a syringe exchange program and continue to inject drugs. So what we see is that the syringe exchange participants who are on methadone compared to those who are not had far fewer fatal overdoses. And they were also less likely to have injected very frequently, to have used heroin daily or close to daily, to have committed theft, or to have engaged in drug dealing. The final two bullet points, of course, are particularly meaningful in the context of corrections as well. Next slide, please. And there are hurdles and obstacles to implementing methadone treatment inside correction settings. This is a study that was done by some colleagues a couple of years ago. We see that there's some stigma associated with pharmacological treatment, and this is the stigma that's held by the staff and people who work at corrections facilities. There's considerable misconceptions about the nature of opioid use disorder. There's logistics and control of storage of methadone, which I am not even going to pretend is not a big deal. Methadone is probably amongst the most regulated prescription pharmaceuticals in the entire country. There's a lot there, but it doesn't mean it's not doable. And we also know that, for example, people, pregnant women often get methadone, who come in on methadone, get methadone while they're incarcerated. So It also could just be an issue of expanding the services that are available to a small group of people to a larger group of people. Oops, sorry, got a little distracted there. There's absolutely an increased workload for nursing staff. There's no getting around it, and there's no getting around the need for nursing and medical staff for methadone. It's not something that a facility could implement without considerable involvement with medical and nursing staff, and it's a workload increaser. So the best way to minimize the increase in workload on the nursing staff would be to have more nursing staff, which is always an issue of finances. And then there's general safety and control concerns. This is woven, to me, to some extent, this is woven into the stigma and misconceptions around how, around what are the realistic safety and control concerns versus what are the kind of stigmatized worst case scenario safety and control concerns. But in the context of methadone specifically, overdose is possible, and disseminating medications beyond the person that it was designed, that it was supposed to go to, is certainly something that can happen and would need to be, the logistics of that would really need to be more, in a detailed way, really drilled down on. This is a photograph of some folks who are engaged in that process by my colleague Sharon Stancliffe. So yeah, let's see, next slide. So there's many different venues for services, both naloxone access and opioid agonist treatment, but these are only two opportunities for services that are harm reduction based that I just decided to focus on as examples. So there's many other other types of services that can also be located or co-located in these venues. So one is drug court. This is a good opportunity to access folks, particularly for overdose education and naloxone distribution, since given that oftentimes one of the sanctions involved with drug court is short periods of incarceration, and even very short periods of incarceration of 2, 3, 4 days can result in a tolerance change that is deep enough or big enough to affect fatal overdose. People who are engaged in electronic monitoring, that's another venue that services can be built around. Bond hearings, and this is an opportunity to oftentimes get at not only the person who's involved in the system, but also their family members and support network. Probation is another place to get at folks. DUI classes is another place to get at folks, and there's many other. I'm hoping I'm gonna only talk for a few more minutes, and I'm hoping that maybe some folks in the audience and the participants have some ideas around what are other venues, have some experience implementing harm reduction and good public health for people who use drugs in the context of different settings. So we're looking forward to hearing that hearing about that from y'all. Next slide, please. Nonetheless, even though these venues are great places to consider hitching services, I think we can make absolutely no mistake and be aware of the contradictions of the health and well-being of people who use drugs and being involved in correction. So the interface with law enforcement, court systems, and non-consensual detention is literally lethal for people who use opioids. It is actually a causal risk factor for death for people who use opioids. I mean, community policing in areas that have more law enforcement, there's a causal relationship with an increase in fatal overdoses. People who are incarcerated, who leave the court system, who leave the court system, are at considerably higher rate for death. And then non-consensual detention, and what I mean by that specifically is like civil commitments. the people who have been engaged in civil commitment are twice as likely to die from a fatal overdose than those people who have never been engaged in non-consensual treatment options. So it feels really important to not you can see that the acronym I use here is people who use opioids. I don't want to mince words about this, that even though we can absolutely hitch services that increase people's chance of survival and decreases their chance of overdose at all of these different points, being the interface with this system is a causal risk factor for death. So next one, please. Given that people of color are incarcerated at higher rates than white people, this is an opportunity to explicitly address racial and ethnic health disparities in specifically overdose, as well as viral and bacterial infection. So that is an opportunity to address the health disparities. But the reason it's an opportunity to address the health disparities is because people of color are incarcerated at higher rates than white people. And so next one, please. I just want to state that racial justice would involve considerable reform of some of the systems. And it's not saying that we shouldn't work to improve the public health of folks who are currently involved in these systems. But if we're looking at some justice, then we really need to examine some overhaul and reform. So at this point, I think I'm going to sort of slow down and hand it over to Matt for us to have a conversation about immediate opportunities to keep people safe in our community. And I see that there's already some questions and comments, so I'm going to hand that over to you, Matt.
Thank you, Maya. I really appreciate it. I was so excited for this presentation because it's an area I can say I truly know not enough about. So again, your expertise in here is greatly valued. And I think, as we talked about earlier, we hope this is maybe part one of maybe a series of presentations we can do on harm reduction. But I'm off topic here, so I should get to my reason for being here. And as again, we just like to provide an opportunity for attendees to ask questions to Maya. And as a reminder, if you've joined us on a computer, you can click the raise hand button on your screen if you haven't already done so, and indicate that you would like to ask a question. If you're on the phone, you press *9 to raise your hand, and we can certainly manage it from there. We will unmute you as on the raised hand option to allow you to ask your question, but please be prepared to ask the question. Keep it brief to allow us to get through as many questions as possible. If your question was asked by somebody else, please click lower hand to remove yourself from the queue. If you'd like to ask questions but don't feel comfortable asking it live, you may ask your question in the Q&A box on the bottom of your screen. We will address live questions first and then move on to the written questions. So true to that, I have a raised hand here, Maya, so I'm going to go to here and allow Janet to speak. Janet, are you, I have to have you unmute?
Yes.
There you go.
Okay, so I just want to know what is the outcome of those that are, I guess, discharged from prison and being connected with the service versus though immediately connected with the services versus those that are not connected and go back to using. Do you have data on that?
Do you mean outcomes in specifically around overdose, or do you mean sort of more general outcomes?
More general.
Yeah, this is a problem. Having assisted referrals actually be followed through with is a sort of foundational problem in healthcare in general, and it's not specific or unique to a correction setting. But first of all, we see treatment retention where there is initiation of MAT or initiation of agonist treatment inside, and then immediately, like, not a referral where you say, here, go see this, here's the directions to go see a doctor who might want to see you, but actually have that have the provider woven into part of the discharge planning is the best way to ensure treatment retention. And I think, I don't know the exact number sort of off the top of my head, but I would say it's like a 10-to-1 kind of ratio of folks who are able to sort of independently follow through with a referral compared to having an assisted, woven together discharge plan that includes treatment access like that. We absolutely see reductions in fatal overdose, and there's lots of studies that show reduction in recidivism with agonist treatment, methadone and buprenorphine specifically. And the article that was referenced in this slide set is a great article on some of those benefits. But even I mean, I know that it's challenging to do an assisted referral system, and then the sort of next best thing is just a referral system. But the follow through is wildly lower, and this is not unique to this context. We see that across the board in healthcare settings.
Yep. Thank you, Janet. Thank you, Maya. A question from the Q&A box here. Although I find merit in 12-step programs, the recovery capital concept has been so helpful. Research has shown 12-step programs have low success rates, yet only total abstinence determines success. Why do you think society is so rigid in looking at SUD in terms of recovery capital?
Yeah, I mean, shoot, it seems like a conversation we could have for hours. I mean, I don't know, Amy, do you have any thoughts on that? I mean, I really appreciate the question, and I mean, to me, this feels like one of the crux of the biggest philosophical conversation that we need to have in terms of improving access to evidence-based treatment, improving access to, I mean, the thing that feels really important to me about harm reduction and the array of options for how people recover, it's been my experience professionally that those who have a deep foundation in harm reduction have the sort of largest bandwidth or biggest umbrella for understanding recovery. And this conversation is one that I think we need to continue having. Abstinence it's a simple measure, and there's a part of me that really honestly wonders if this using abstinence as the success isn't something that hasn't been reinforced by researchers in general, simply because it's so simple to measure. Things like quality of life, general well-being, satisfaction and joy and completion, human interrelationships, those are really challenging things to quantify in a research study. And yet, by and large, substance use disorders are kind of defined by dysfunction in interpersonal and social relationships. And those, an abstinence just, it's too simple. So anyway, I think I'd love to continue having this conversation ongoing. Yeah, yep. I think that's a really important one.
I agree. Thank you. I have a raised hand here. So Jesse, if I do this correctly, hopefully if you unmute, you should be able to ask your question.
Yeah, I think she answered my question in the last statement that she made, that abstinence don't equal recovery, but the other holistic dynamics is what equal the recovery process. So in harm reduction, harm reduction is a good piece to add to the systems of change, because you have a lot of individuals that's not just ready for abstinence, and you can engage them in treatment when they're not ready for abstinence. So I think harm reduction is an excellent piece. It have helped me in my ability to administer recovery to everybody. And I think soon the terminology transcendence will be added to the recovery processes in the future too, because you got some people that will transcend out of the place where they will ever or never use again. So that's another piece that we have to add. I mean, we got multiple pathways to recovery and leaving addiction and living a qualified life. And so you answered my question with your last statement. I had raised my hand and you had already answered it. So,
All right. Sorry about
Jesse,
Go
that
ahead,
I,
Jesse.
oops, sorry. I just wanted to say, one of the things that you brought up about sort of expanding the ways that you can work with other people to engage in recovery, that I'm so glad you mentioned that, because I feel like over the years with people whose job is treatment and recovery, I've heard this kind of mantra of there's nothing we can do until they're ready, which is, it's important to not push people. I mean, we talked about the sort of non-consensual treatment and non-consensual, detention for treatment. It's important to not push people until they're ready, but people are so frustrated when there's nothing we can do until they're ready, but there's actually tons that we can do. In fact, like the treatment, if we're doing stage-based treatment, when somebody is in contemplation or preparation, there's enormous amounts of, sort of treatment interventions that we can do if we embrace harm reduction. That's part of helping folks get into, part of the recovery process. And so I also just want to point out that, like, it feels like a frustration reduction strategy also to offer up an array of harm reduction services for people involved in providing treatment services, because there is stuff we can do before somebody's in action, that action stage. So thanks for that, Jesse.
Yeah, I agree. Thank you, Jesse. And it goes to a question kind of I had, and it's my own professional ignorance is that one of the challenges I have, I hear a term harm reduction and I create my own definition, right? It's like one of those words in the professional realm that crossed over into the general vernacular of the population, and it means different things to different people. So, again, I think I know what harm reduction is, and sitting and listening to you, Maya, and your presentation tells me I really have a very limited understanding of what harm reduction truly means, because I made my own definition as based on what I thought the words harm reduction means. So just putting that out there a little bit too. So my own self-disclosure. But and Maya, I'm not sure if you have any data on this, but again, certainly the center would be able to get the data for Pamela, and there's some others that like. The question was, how many correctional settings, county jails, or prisons in Michigan are distributing naloxone upon release at present? Any yet? Not aware of? Please advise.
Yes, thanks for that, Pam. So to my knowledge, naloxone upon release, people who are walking out of the door with naloxone, I don't know that it's really happening. I see that, let's see, Amy said that the Red Project is working with inmates in Cook County, and that recovery coaches from the Red Project have been providing that, which is great. I see that Nancy King said that in Kalamazoo, they're working with jails to distribute naloxone as they leave. I want to acknowledge that it's complicated to get it up and running. I would say that it's worth the extra complication to figure out how to be sure that people walk out the door with the materials in their hands. Not even asking them to cross the street to go pick up the naloxone. So it is challenging. I know that, for example, Cook County Jail in Chicago has been doing it for about 6 or 7 years. 5 or 6 years. The LA County Jail is doing it. Rikers Island is doing it. I please, anybody else who knows more about Michigan, put it in the chat box. But I know that this is also an issue that Pam has been working on for many, many, many years. And it's, I feel like we need help with this. Like,
Well,
can help with this?
I'm going to jump in here a little bit, Maya, and talk about the Center for Behavioral Health and Justice and our work with Naloxone. We're currently involved in 21 counties throughout the state of Michigan, and we're in the process of rolling out Naloxone availability to all the county jails that we're working in. We're looking to really use a three-tiered system. In a more micro level, we are actively in 5 county jails helping facilitate MOUD programming inside those facilities, and part of those models that have been adopted by those stakeholders is making naloxone available to the individuals who were participating or opioid involved prior to the incarceration. So this is a bandwidth area that the center is very interested in pursuing further. If there are other members of our attendees here who want more information about naloxone distribution in the state of Michigan, the center stands ready to partner with anybody to try and roll those efforts out and expand them into an even a greater extent. As Maya's information showed and what we do know from naloxone, its effectiveness is undisputed and it saves lives. I found it interesting in Maya's presentation that half the people coming out used it on somebody else, right? It's like, I think that in itself is a testament to the effectiveness of the antidotal qualities of naloxone. So that was my little pitch for the CBHJ. But again, this is something we believe very strongly in, and we think there's a great opportunity to meet with people here. So I'm going to go to another question here. It's so from Audrey, in the stages of pre-contemplation, do you use techniques like motivational interviewing?
Yeah, that if there's anybody here who's a motivational interviewing a mentee, I would absolutely invite you to raise your hand and join me in answering this. I'm not a motivational interviewing trained person. In my professional career, so yes, motivational interviewing is one of the things that you would do in pre-contemplation. But another thing that's important about pre-contemplation is to sort of, subtly help people examine their decisional balances, their decisional balance, but focus on like health and well-being and satisfaction, and sort of take a step back from the drug and get in. And if you're engaged with people who you would say are in pre-contemplation, it's a good opportunity to establish relationships. It's a good opportunity to confirm to people that you prioritize their health and that you're not going to be judgmental by doing things like actually either providing like syringe services or making active referrals for syringe services if people are injecting. But I think taking a step back from motivational interviewing that is drug focused is helpful in pre-contemplation, because that's your window to develop a relationship where people are going to believe that you're going to be non-judgmental and trust that what you have to offer is going to be helpful and meaningful for them, especially if you can offer something that's helpful and meaningful as defined by them while they're in pre-contemplation. I don't know. So I'm wondering if anybody who's a mentee has raised their hand who would like to expand
Well, a hand
on
came
that.
up pretty quickly as you asked, so I'm going to open up the mic to Antoinette and see if you unmute yourself. I think you should be able to speak, Antoinette.
Good afternoon, everyone. Yes, I'm a motivational interviewing mentee, and when I use the technique, I don't just focus primarily on substance abuse. We would generally focus on their whole path of what they're doing and just in general case management. We might whittle it down if it continues to be an ongoing issue and other things weren't working. But ultimately, we just, with motivational interviewing, we just basically keep putting it back on them until they kind of sort of come up with the solution on their own. And we're just there to guide and kind of redirect them in the path.
Perfect. Thank you. I appreciate that very much. All right. I just have to do some things here. I did get an update from Darren here that Michigan prisoners leaving on parole are now getting naloxone kits. Michigan Department of Corrections has also started a Vivitrol pilot program. I think, Darren, too, the MDOC is also looking to start a full MOUD program. They're piloting it in 2 facilities and then looking to broaden it out to the entire prison population where applicable. So, but again, it's good to know that MDOC is leading the way in terms of showing the jails that this is something that can be done. And the center, again, is working with our local communities to try and both the specialty courts, the jails themselves, and any other interested parties. I like the idea of visitation as being an opportunity. Maya, I thought that was a great point in terms of naloxone distribution. I know many jails have gone to video visitation, but many video visitations are still occurring with the video camera inside the jail or the visiting room inside the jail. So an opportunity for us in the center to think about, well, there's a possible reach point for us as it goes. So really great information that way too. So we have just a couple of minutes left. I'm just going to say here, Maya, it's less of a question, but is there any videos that you're aware of to show law enforcement about really what harm reduction is and how it operates that we could suggest to sites?
Yeah, yes, actually. Let's see, I would suggest going to the Harm Reduction Coalition, the National Harm Reduction Coalition's website. They just redid it, so I don't know, I don't have the trees and branches in my mind quite yet, but I know that there's probably 3 different videos that are law enforcement focused around syringe services, as well as naloxone access that the National Harm Reduction Coalition has used or was put together. And then I would also look at the North Carolina Harm Reduction Coalition's website for some resources, and maybe. Well, that's where I would go. That's where I would go first. And perhaps after I can't Google and talk at the same time. It's just, it's not going to work. But perhaps after this is over, I can connect with Matt and Becca with some links to some of the services that I think are great. So, or not services, videos.
That'd be great, and we would certainly pass them along to all the attendees today. So, any information along that line. So. Again, I'm just going to do my sign off, Maya, and thank you for your great presentation today. It was a really informative and educational for me personally and professionally, so I greatly appreciate it. But I'd also like to turn it over now to Becca to kind of go with some closing comments and keep us true to time here. So, Becca?
Thank you so much, Matt. I appreciate it. I will echo Matt, and I hope everyone else's sentiment as well. Thank you so much, Maya, for presenting today. And thank you for everyone else who joined us here today for this OT Community of Practice Lunch and Learn on harm reduction. A recording of this webinar will be posted on our CBHJ website and our YouTube page within the next week or so. We will also send a copy of the slides and related materials to all attendees as soon as we can, as well as answers to unanswered questions that were put in the chat box. Please keep an eye out as well for future events in this series. The webinars will be held every other month, so the next one will be scheduled in February. Last, but certainly not least, it's important to us that the content we share is useful and relevant to the work that you're doing, and we greatly value any feedback that you have. So we do and would appreciate you taking a moment once the webinar ends by clicking the link that pops up on your screen to complete a very brief survey so that we can collect this feedback and continue to provide pertinent topics and great presenters to everybody who attends these webinars. Thank you again, everyone, for joining us today, and we will talk to everybody soon.